access to these drugs is difficult. Where does the specialty pharmacy come into the picture? How do they work into this?
I think getting patients on drug therapy with PCSK9s is a multi-pronged approach because we have patients who are not in specialty pharmacies. We have prescribers who aren't in specialty. So it's really direct-to-consumer information and education, consumer and prescriber. It's also helping those patients with supportive educational services.
What does that mean?
So you have different, it could be a website, it could be an 800 line. It's information that allows these patients to educate themselves and then to bring that information into their physician office. It also serves as a resource for the prescriber.
I mean,
many times these hurdles that need to be jumped through to get these patients on therapy, that it's substantial. So having a support system in place. So these are patient and provider facing services that happen. Many times this happens in a hub setting. It can happen at the pharmacy level. But this class of drugs, I think you're seeing a lot of heavy lift go on with these supportive services.
Yeah, and I think you mentioned earlier one of the challenges with specialty pharmacies is cardiovascular disease has not historically been a specialty category. So if specialty pharmacy is now managing the PCSK9s, they're not managing the oral diabetes drugs, they're not managing the ACE inhibitors and the statins and everything else. And so it really gets back to, again, the data and managing these patients a little bit differently from a care management perspective. But I agree, I think the benefit of the SP or the specialty pharmacy is, again, an education back to the patient and to the provider, but also maybe a coverage determination, helping the physician's office understand the different criteria that payers require, and even support and even applying the coupons for patient assistance programs if done appropriately.
Exactly. So these drugs are broadly distributed, so they are broadly available. When the drugs do wind up in specialty pharmacies are equipped to deal with all aspects of that patient. So pulling in information on comorbid conditions as well as all of the drug therapy, and then helping that patient to stay compliant.
Well, let me ask it this way: how does the physician involve the specialty pharmacy in the first place? In other words, I want to give this drug. I'd like to get it approved. Do I call my local Drugs R Us, or do I call the specialty pharmacy right away?
Well, the prescriber community here is it's vast, right? It could be the surgeon writing the script, it could be the cardiologist, it could be the general practitioner. So that's a very large prescriber base. Specialty pharmacies are generally dealing with specialty prescribers, oncologists, immunologists, rare disease experts, geneticists. So that community of prescriber isn't familiar with the specialty pharmacy. They're generally writing prescriptions or electronically prescribing. So these prescriptions are winding up across the channel.
Okay.
So the approach to deal with these medication has to be a channel-wide approach.
Should there be a trigger? If the drug costs you more than $1,000 a month, that gets put right over to the specialty pharmacist?
Well, many times payers do that. So these drugs are at times winding up in specialty pharmacies, and it's for the cost reasons right now. It's cost as well as patient education. We haven't really talked about the difficult administration and education that goes around that for these patients.
Just going to get there, because these drugs are not pop a pill and a good night.
Exactly. And these patients aren't necessarily, unless they're comorbid and they're using insulin for diabetes, they're not used to injections. So there's a great deal of training that has to go on with the patients before they're able to inject themselves,
and
twice
that's
a
what
month.
the specialty pharmacy can do that.
Specialty pharmacy is equipped to do that, absolutely.
And the specialty pharmacy and or the payer somehow also needs to be appropriately following up with that patient every month, every 2 months, rather than just maybe auto ship refills. That's another touch point, and that's another opportunity for specialty pharmacies to help educate the patient.
Do you see yourself in the specialty pharmacy as a patient advocate? Do you see yourself as the point person? If the doc can't make this phone call and can't drive this to approval, you're going to do it?
I think that's really the genesis of specialty pharmacies. It's difficult therapies and it's challenges to access for these patients. That's really where specialty pharmacy fits. as far as advocating for that individual patient, you know, we look at all of the criteria for use. The majority of the drugs that we deal with in specialty require prior authorization. The PCSK9s, 99.9%, are going to require prior authorization.
She's on your phone all day long.
Yes.
Right,
yes.
but that's part of the issue though with SPs and payers is we understand there are definitely positives associated with specialty pharmacy, the augmentation of programs. Part of a challenge though is if you have a certain SP who is
Go on, just say it.
playing the pill game and doing things that are maybe inappropriate to drive utilization, then there's a little bit of disconnect there. So just like there's importance with collaboration between the payer and the provider, it's important to collaborate between the SP
Yeah,
and the payer.
I'm not sure. You know,
I can give you all kinds of examples on where drugs are going out that are questionable.
We probably have about 250 or so specialty pharmacies that are accredited by URAC, ACHC. So specialty pharmacies go through accreditation and have policies and procedures in place to support quality initiatives, and each and every aspect of patient coming through the system is auditable. So, you know, with respect to some of the things that are going on, I wouldn't let a couple of bad apples kind of spoil the great work that specialty pharmacies
He
do.
was just dumping on specialty
Yes,
pharmacies.
it was.
I wasn't. I just said the key
That's
is,
what I heard.
The key is collaboration because the
It is
incentive, there,
collaboration.
just like with other stakeholders, there is a potential for misaligned incentives.
Yes.
It is still the payer's money. So the criteria and the process and the refill process and everything else has to be appropriate.
Is it the payer's money or is it the patient's benefit?
It's the employer's money. But if you're
Or
fully
is it
funded, it's the payer's money.
Most of the time, they're, you know, commercial patients, they have a job, it's their benefit. So I think we owe it to the prescribers and the patients to appropriately vet the patients for therapy. I mean, we've talked about what is to label, and there are probably a million patients out there that probably could benefit from this. So making sure that we're going through the criteria and hopefully working with guidelines that we hope will be updated with some sort of a, you know, tried and true measure of success as the science continues to support this. You know, then we'll find a way to make sure that we are treating these patients.
But I also want to get back to something you just said, and it was in contradistinction of an attitude. And I don't mean a bad attitude, simply an attitude, which is you said it's the employer's money. And you said, well, it's a benefit they negotiated. It's really the employee's money that he's or she has deferred for health care, right? Can you both be right?
It depends on if you're self-funded, fully funded, what, you know, there's different, there's other issues that go into that, on whose money it is.
I mean, I'll tell you what an employee might say, gee, my union went in, negotiated, and I got less money in my paycheck, but I got a health
Got my
plan.
benefit.
That's my benefit. That's my money.
Yep.
It's not my boss's
So the
money.
question
It's
is,
my money.
the question is, end of the day, is who's paying for that claim?
Okay.
Let me ask you that question. Who's paying for that claim end of the day?
Well, who is paying?
Who's paying?
Who's paying?
The member pays a copay.
Right.
The health plan or employer is paying for that claim end of the day.
But who's
I don't
funding
know.
the employer's bank from which that pay comes? Isn't that what you were saying?
Right. I mean, I believe that it really starts at the patient or the employee, and you know, as long as we are looking at appropriate utilization of drug therapy, that's the patient's benefit.
I think with high deductible health plans, it's a little bit gray now. It's grayer than it used to be. I mean, people are more responsible, directly responsible for some of their costs.
So
than
are
they
you saying
used
that
to
people
be.
may auto decide to stay with the lower drug? That they don't need the heavy hand of the payer to do that for them?
Patients are being more, they're
becoming more
consumers.
educated
Yeah,
about
they're
the
being,
cost of it.
yes. So I think, you know, to some extent, I would agree that it is the patient, or, you know, it's the patient's benefit and the money. I see both sides, so I think you can both be right. I do.
See, that's why she's in the
But-
middle. She sees both sides.
From a clinician standpoint, I am mostly looking at the patient. I try to be cost conscious for patients, but I also want to do clinically what's best for the patient.
Well, I think-
So
yeah.
just they have to be educated and make their decision. But especially if it's, you know, especially I see a lot of our own health plan self-insured people. I want to be cost conscious for the business as well. So it's definitely, I think most clinicians are weighing that in their mind as well.
But wouldn't we all agree that if we prescribers prescribed and payers paid according to label, that's appropriate use and should be covered.
Yeah.
Okay.
All right.
Okay,
That's the
let's
common
move
ground.
on.
But it was brought up that 80% of the time, I think you said 80% of the time these claims aren't being
That was a number I
right?
do
That
remember.
is, that
So,
is.
so there's the issue.
And
Is
there's
it
a
80% of the time these drugs are not being prescribed appropriately, or what's going on?
Is it that,
I don't
or
know.
is it the payer's criteria for utilization? We heard from the clinicians that they're not doing necessarily the genetic testing or some of the other requirements. So the payer's bar for approval of these drugs is here in some cases, and the patient doesn't have that information to support because their provider is not doing that type
Right.
of diligence.